Welcome to our ethical case analysis.
Picture this. A 90-year-old female comes into the emergency room from home by EMS. A neighbor called 911 because she heard a loud thump and screaming coming from upstairs. An overall scan showed that patient X has a broken humerus and a bowel obstruction that requires emergent surgery. Patient has altered mental status and is unable to give consent. A pulse form was found posted on her refrigerator by EMS and states that she is a DNR-DNI. Do you suspend the DNR-DNI? Do you continue to do surgery with the DNR in place? What would you do? The ethical issue in question is the automatic suspension of advance directives which include DNR-DNI orders preoperatively. The first person who brought this to light is Robert Truog. 1 year after passing the Patient Self-Determination Act of 1990, Truog wrote a paper analyzing the management of DNR orders of patients who require anesthesia, surgery, and an invasive procedure. Because of this paper, several organizations began making statements and practice guidelines. According to the AANA, along with other organizations, automatic or mandated suspension of DNR orders is unethical and goes against patients' right to self-determination. It also violates the ethical principle of autonomy. Mandated suspension of a DNR order is not appropriate. A discussion with the surgeon, anesthesiologist, and patient or surrogate should take place to provide an explanation to the patient about the issues particular to the administration of anesthesia and the proposed procedure. It is important to follow and respect the patient's wishes regarding their code status. Despite the consensus statements and practical guidelines set by varying organizations that describe the inappropriateness of automatic suspension of DNR orders, large number of anesthesiologists and surgeons report a frequent practice of automatic suspension. This is some of the data found in studies regarding this ethical issue. One study found that 55% of anesthesiologists were unfamiliar with ASA and ACS guidelines on advance directives in the perioperative setting. Another found 18% of anesthesiologists and 38% of surgeons believe that DNR orders should be suspended automatically. Additionally, 63% of CRNAs report unfamiliarity with the concept of required consideration, which will be discussed further later. In a separate study, 59.3% of CRNAs reported that their hospital policy was routine suspension with patient informed.
We will be using Johnson's 4 topics approach to help sort out the facts, address core ethical values, help facilitate discussions, and ultimately resolve the ethical issue at hand. To start, it is first important to emphasize that DNR simply means do not resuscitate. It does not in any way mean do not treat. Johnson's first topic is medical indications, which is built on the ethical principles of beneficence and non-maleficence. This framework helps analyze the case study because it is important to consider the medical indications of taking patient X to the OR. For example, what are the patient's overall medical problems? Are they acute, chronic, or terminal? What is the long-term prognosis post-op if the surgery is successful versus unsuccessful? And lastly, what are the overall goals of treatment and surgery? Are they curative or palliative? All of these questions should be discussed in detail and transparently with the patient or surrogate decision maker. Johnson's second topic is patient preferences, which is based in the principle of respect for autonomy. As the healthcare field has adopted the idea of patient-centered care, the concepts for shared decision-making, patient autonomy, and patient preferences have become top priorities. Now more than ever, patients are encouraged to advocate for themselves by making their wishes and preferences known in regards to their care and treatment. The various types of advance directives are all ways that someone can decide their end-of-life preferences before they are no longer able to do so. As done by patient X in our case study, the pulse found by EMS states that she is a DNR-DNI based on the patient's decision-making when she was of sound decision-making capacity. Patient X was fully informed of the benefits and risks to CPR and intubation by the provider who also signed off on the form. However, as we fast forward to patient X's need for emergent surgery, we need to consider some very important topics. For example, is the patient mentally and legally capable to make decisions? If the patient is not able to do so, who is the appropriate decision maker, and have they been informed of the benefits and risks to surgery? Does the patient want treatment at all? Do we have informed consent? As discussed by Truog in 1991, after the passing of the Patient Self-Determination Act of 1990, he called attention to the common practice of automatically suspending a patient's DNR order when they are taken to the OR. He argued that this violated the federal act by disregarding the patient's autonomy of the pre-existing DNR order. While a significant number of patients with DNR orders agree to have surgeries and other procedures, many of them are palliative in nature. For example, procedures for tracheostomy, gastrostomy, bronchoscopy, and catheterization for central venous access could all be seen as palliative in certain circumstances, and historically, all of those DNR orders were suspended during such procedures. The AANA has created a code of ethics composed of 6 provisions to guide CRNAs as they address ethical issues within their daily practice. The first provision is directly related to Johnson's topic number 2, discussed on the previous slide. This provision addresses the responsibility of the CRNA to protect the patient in all aspects, including moral, legal, patient safety, and well-being. As the CRNA caring for any patient, you are the patient's advocate throughout the entire perioperative experience, and you have a moral duty to provide holistic, compassionate, patient-centered care in collaboration with the healthcare team. In relation to this case study, it is the duty of the CRNA to protect patient X's preferences, which is her DNR status. Johnson's third topic is quality of life, which is rooted in the ethical principles of beneficence, non-maleficence, and respect for autonomy. This topic, although self-explanatory, is very important. A patient's quality of life is a huge influencing factor of the decisions that are made in regards to their care. As in the case of patient X, we have to consider what her long-term prognosis will be, as well as what the patient's quality of life will be post-op if the surgery is successful versus unsuccessful. Are there any plans to move to comfort measures? Johnson's last topic is contextual features. This identifies any factors that may influence the medical decisions being made, such as professional, legal, financial, or institutional, to name a few. Any of these factors could contribute to the development of a conflict of interest and potential bias toward decision-making. This topic is built on the ethical principles of justice and fairness, which tie into the fact that all patients should be treated equally and fair. In relation to the case study, there could be quite a few contextual features at work. The first could be the prevention of deaths in the OR to keep good hospital-wide statistics. As a result of the pressure from the institution to maintain good statistics, many providers will push patients or families to rescind DNR orders to prevent intraoperative deaths. As many of us have seen within our own hospitals, patients don't die in the operating room. They will code either in PACU or as they get wheeled into the ICU. Another influencing factor is to consider patient X's age. Some providers may feel that because she is 90 years old, that she should automatically be placed on comfort care. That is not the case here. Some individuals may be fully independent and well-functioning at 90 while choosing to be a DNR, such as patient X.
So how can the healthcare system address this issue? Required reconsideration is a policy in some hospitals that emphasizes the responsibility of the anesthesia provider and surgeon for obtaining documentation and providing a rationale for DNR suspension. The AANA's ethical guidelines for reconsideration of advance directives suggest that there are 3 alternatives to consider when caring for patients with advance directives during anesthesia care. Full suspension is where all provisions of the advance directives are suspended during anesthesia and the procedure for a specific period of time. Partial suspension or modification talks about how only specific provisions of the advance directives are suspended or modified. No suspension means the provisions of the advance directive remain active during the anesthesia and procedure.
In this practice guideline, there are several components included which would help the CRNA navigate throughout the process. Most notably, discussions with the family regarding the interventions that the patient wants and does not want regarding anesthesia under specific circumstances is vital during this conversation, so that they can make an informed decision on their course of action regarding their advance directives. The guideline also talks about communication. CRNAs must remove acronyms and clinical jargon when discussing the plan with the family. It is important to consider the patient's unique emotional, cultural, and spiritual values during all communications. Additionally, a CRNA is allowed to electively remove themselves from the procedure if you feel like it breaches your duty of doing no harm. However, there has to be a facilitation of transfer of anesthesia care to another credentialed provider who can respect the patient's wishes without feeling like it goes against their own beliefs. Documentation is very important here. You must include date and time of discussion, who you spoke to, a summary of the plan, any modification to the advance directive or interventions during the procedure. An often overlooked component is when should the changes to the advance directives take place and when should they end post-operatively must also be documented appropriately. Lastly, under the anesthesia and interdisciplinary team communication guidelines, explaining the discussion with the team regarding the patient's wishes is very important. They also recommend including the modifications to the advance directives as part of the checklist to enhance communication and understanding of the patient's wishes.